everybody, and welcome back. This is Peter Pronovost, and today we're going to cover the evidence supporting ICU physician staffing. Now, I'm in no way implying that we don't need to think about nurse staffing or pharmacy staffing in the ICU. It's just, one, this is my area of research, and I happen to be spent a lot of time doing this, so I want to share with you some of the evidence. So the objectives are to review the evidence on the benefits of ICU physician staffing. And when I say physician, I include nurse practitioner and physician assistant in there. And then to explore strategies of how you might improve your ICU physician staffing given your culture and your resources. So what are some of the organizing principles of critical care or intensive care? Well, these ideas come from the Society of Critical Care Medicine, and they're quite simply that the patients are our North Star. They have to be how we organize care around them. That we have to give them the right care right now, and in critical care, right now often is important. And we do it by an integrated team of dedicated and competent experts. That's what all of you are. Now, there's quite substantial evidence that intensivists reduce mortality when they are involved in the care of patients in the ICU. We don't actually know how that happens, but we know that it does. This is a slide from a systematic review that I published with our team in JAMA back in 2002. What we did is we summarized all the studies that looked at the benefits of intensivist staffing and classified them into high intensity, that is either a mandatory consult or the intensivist rounded every day, versus low intensity, that is they were either no intensivist or they were an elective consult. And what we found is that the high intensity group, when you had an intensivist, you reduced hospital mortality by 30%. And you reduced ICU mortality by 40%. Now, ICU mortality is a little trickier because you don't know how sick people were when they left the ICU. But either way, there are few, if any, therapies that reduced hospital mortality by 30%. And this isn't one study. This is a collection now of our review included about 29 studies. Now, recently there was a study in Annals of Internal Medicine that's referenced at the end of this that showed that intensivists may have a higher mortality when they care for patients. It's hard to know what to do with that. I suspect it's likely inadequate adjustment for severity of illness, but that has to be compared to the substantial body of evidence and a much larger number of studies that show benefit. And not only is there clinical mortality benefit, but there's cost savings. My colleagues and I published a study looking at under virtually any scenario, and this includes the hospital paying for intensivist. Right? So make sure that's clear. Hospital paying for intensivist. That putting a hospital in through reduced length of stay primarily and other costs is associated with a net savings for the hospital that's often substantial. Our colleagues working for the Leapfrog group also did a similar economic analysis and remarkably found almost identical savings. So two independent groups looking at this data. What does that turn out to in savings? Well, under the baseline case, it's about $700 per day. In an optimistic case, it's about $1,000 per day. Or it turns out to be about $3 million a year for an average ICU. Now, because of these savings and the clinical benefits, the Leapfrog Group, a consortium of Fortune 500 companies that said we're tired of not buying healthcare right. That is, when we buy steel or when we buy any other item, we know the quality of what we're buying and we can buy wisely. That is, we can make a trade-off between cost and quality. In healthcare, there's no such trade-off. It's invisible or opaque, or performance is not even known. The Leapfrog Group, about a month after I published this study, called me, a gentleman, Arnie Milstein, and said, you know, Peter, I read your study and we're thinking of making it a national standard. Me, being a typical academic, was cautious, saying, you know, it was observational, they weren't randomized. Arnie says, do you believe it, Peter? And I said, well, yes, I believe it. I practice medicine. There's a lot of studies. And then he said, well, come out to General Motors headquarters. We want you to talk to some leaders out here about your study. Little did I know that they called the CEOs and CMOs of the 14 biggest managed care companies in the country. And on the podium, the executive director of General Motors stood with his arm around the head of the automobile union. As you know, these two people would be fighting constantly over wages, but they weren't. They had their arms around each other. One in a several $1,000 suit and one in a golf shirt. And what they said was, when there's a death on our shop floor, we investigate it, we learn, and as a result, we have a very, very safe work area. But yet every day, 1 to 3 GM employees or their dependents die because there's not an intensivist staffing the ICU. And that's not acceptable. So we're going to demand that you start putting intensivists in ICUs around the country, and Peter's going to tell you the evidence. And then they threw me up there, and that was a whirlwind beginning of employers saying, we're not going to accept the status quo anymore, that we are going to have a culture of accountability over complacency. Now, how does intensivist staffing realize this 30% reduction in mortality? Let me be the first to say we do not know. But I've thought about it a lot, and I think there's 4 key attributes that we can try to create. The first is that they're present. That is, they're there in the ICU. They're not in their office. They're not in the operating room. They're in the ICU where work is done. Second is they possess some core knowledge or skill of this area, and the knowledge and complexity of both the treatments and the monitors is growing daily. So you need to have someone who's up to date on this knowledge, just like you want your primary care doctor to know about primary care medicines. Third is that they work to communicate with the other members of the care team and the patient. They're kind of the quarterback. And lastly, and I think critically important, they manage at the ICU level. What do I mean by that? Well, they're not just only looking at what does this patient need and I'm caring for this patient. Rather, they're up on a balcony looking at what does the ICU need. So what protocols do we have? Do we have discharge criteria? Are we putting in our protocols? Are we monitoring quality? So much like there's a nurse level managers in most of our units in medicine, intensivists can function as the physician level manager of an ICU, and that role is critically needed. Now, we can think of ICU physician staffing as balancing between 2 extremes. On the one hand, a 24/7 intensivist staffing, and on the other, no intensivist. Now, in many ICUs, 24/7 isn't at all feasible, and if you're a small ICU, it may not make much sense. So how do you think about this? If you're going to look to put in an intensivist staffing, these ideas come from years of catching spears and getting it wrong. I offer some thoughts. The first is avoid this open and closed debate of the ICUs. It is inherently confrontational and non-productive. Rather, frame it as team care, that the primary care physician brings value that is indispensable, and the intensive care physician brings value that is indispensable. And together, patients will get the optimal care. So that doc who knows someone for 20 years, I need that information when the patient's admitted to the ICU. At the same time, the primary care doc has to recognize that I have special knowledge and skills, and I'm there putting out fires, preventing harm that adds value to them. And together, patients will get the most care. I think there's undoubtedly evidence that the hospital benefits from putting intensivists in. So there has to be some degree of financial support from the hospital to provide for the intensivist to staff that. Now, how much and what form it takes varies widely, from a stipend to some salaried support, and you'll have to negotiate that yourself. But there often has to be some flow of dollars from the hospital to the intensivist team. But for that, there has to be a compact explicitly, unambiguously of what is expected for this. It generally includes some commitment to measure and improve performance. I hope in this case it includes measuring and nearly eliminating bloodstream infections. And there often needs to be some admission and discharge authority. That is, if the intensivist doesn't have any ability to say, well, I'm here, but I don't need to round on patients, or I don't have any ability to get patients out of the ICU, you're not likely to see either the clinical or the economic benefits of intensivist staffing. What might be some strategies if you're trying to embark on this way? Well, I'd suggest meeting with your medical staff. Review with them the evidence that we've provided here and have an open discussion about, could we take a team care approach? I would avoid this open and closed debate completely. It's non-productive. And then work to create this compact with the hospital. Clarify explicitly and unambiguously what the hospital will provide, typically financial support, but it may also include quality improvement support for measurement and improving things, and what the intensivist staff will provide. They will round on every patient every day, they will monitor and improve quality, and agree on some regular performance reviews. We will look at this quarterly to make sure that we're both meeting our obligations. When that's done, intensivist staffing could be implemented with great benefits to the patients, great benefit to the hospital, and great joy among the medical staff. Now, if intensivist staffing isn't in your cards, either because you're rural, you just can't recruit them, what might be some alternatives? Well, what I would say to you is go back to those ideals, or what are the attributes of being present, being knowledgeable, communicating, and managing at the unit level, and say, what could I do to achieve those attributes? And I have some ideas. One could be work with your hospitalist and have hospitalists provide care in the ICU. They're doing it now in many, many, many hospitals around the country. Work towards regionalization. That also could involve hospitals. So you may have an intensivist who really oversees the sicker patients and hospitalists and others who care for the less sick. Consider employing nurse practitioners and physician's assistants in your ICU. We have them in my ICUs, and they're indispensable. They're kind of the organizational history of making sure that the protocols are followed, that we implement best practices, and that could be a strategy. And you may think of others. I know some of our hospitals in Michigan put in emergency physicians and a variety of other strategies. Second, make sure that there is a physician who rounds on every patient every day. That being in the ICU poses benefits, or could pose benefits, but it also imposes risks. And if patients are going to be exposed to those risks, we need to make sure that they also reap the benefits. And that is rounding, clarifying what it's going to take for them to leave the ICU, and explicitly what work are you going to do today towards that goal. And finally, make sure your ICU has a call list. That is, at all times for every patient, do the staff know who to call, who is the responsible physician. It's remarkable on how many ICUs I visit where that is unknown and it poses hazards. I would recommend for you as an action plan is discuss with your team in your hospital, what is your current ICU physician staffing? Are you happy with it? Are you meeting these attributes? Do you have an intensivist model? If you could, develop a plan to enhance your ICU physician staffing. There's no doubt that the evidence of the mortality and the economic benefits of intensivist staffing is profound. Indeed, it looks like about a 30% reduction in your risk, a relative reduction in your risk of hospital mortality. And work towards creating those attributes in whatever way that meets your culture and your resources. Believe me, I know you work in a variety of different hospitals with different cultures and different resources. And our Michigan colleagues were exceedingly creative in doing new models to meet those attributes. But with very little resources, you could ensure that the nurses always know which physician to page unambiguously, and work with your hospital to create a compact. That is, clarify exactly what the hospital will provide and what in turn the physician services will be provided. And that ought to include some monitoring of quality and some efforts to improve performance. I would strongly encourage you to put monitoring and reducing bloodstream infections on that compact, because that's what this whole project is about. And we know that with your leadership, we're confident you could work to eliminate those infections in your ICU. This is Peter Pronovost working with you to improve patient safety. Have a great day.